Perfect. Hi, everyone. Welcome to this evening's talk on different study designs in clinical research. My name is Shiv. I'm the president of the British Orthopaedic Medical Student Society, and I'm pleased to announce that this is our fourth lecture of the series. So thank you all for joining. Hopefully you've been to some of our previous lectures and have seen kind of what we're aiming to do with the series. And it's my pleasure to introduce Mr. Chris Bretherton and Miss Emma Reay to deliver this talk. Chris is a past PhD student, now a SD7 Reg in the Thames Valley Deanery. He's also a big supporter for collaborative research and has led multi-center trials and audits, as well as priority setting partnerships. He's also the previous BOTA academic rep and had the pleasure of being on the committee with him back in the day. And it's also a pleasure to introduce Miss Emma Reay, who's a consultant orthopaedic hand and wrist surgeon down in South Tees, and is also the co-chief investigator for the FLAIR trial, which investigates the repair of flexor tendon injuries of the hand. So without much further ado, I'd like to introduce Chris to give the first part of the talk. Thank you.
Hi, Chris, could you please share screen?
Great. All right, I'll go ahead with that.
Yeah, we can see it perfectly. Thank you.
Yeah, lovely. So I'm going to tell you about reviewing a research study or study design, and ultimately, what we're trying to get to is talking about randomized control trials and why they're probably the gold standard of research studies and studies that you should be looking to participate in and run. But the way we're going to do that is we're going to talk about some of the theory behind other kinds of studies, and then think about why we might not want to use those and some of the biases that they have within them. So what we're going to look about is internal validity and external validity. So internal validity, we want to try and design a study that is precise and that is also accurate. And so we'll talk about those terms and what they mean, and then look about observational study design, and then look at some sources of bias. So when we're thinking about studies, the word accurate really means that the study has sampled enough of the population, and it is so accurate. Something that accurate is precise is sort of explained by this sort of target, and it's the answer is right in the middle of this target, and it's very tight, and we know that the study answered the question that it set out to do. This is an example of a study that was precise but not accurate. That means that the effect, we know that the effect and the confidence are very tight. However, because of some systematic bias, it is not an accurate study because it wasn't really answering the question that it set out to answer. Here we've got an example of a study that is accurate but not precise. It's accurate in that it was studying the sort of true area of what it was trying to answer, but usually because the study was too small, we don't know with much precision what the true effect of a intervention might be. And then this is a study which is neither accurate nor precise, in that there's some bias in there, and it wasn't really measuring what it meant to answer, and also it was a bit varied, and we don't really know for sure what the effect was. So again, this is just an example of a study here. This is a study that is accurate but not precise. And this is an example of a study that is precise but not accurate. So you'll have to just stay with me as we just try and get through these terms, because when you sort of think about these terms, you realize why we do studies in a certain way. So the way to improve precision is to decrease random error, and that will tighten your confidence intervals. And the way to do that really is to sample more of the population. So if you sample more of the population, then you can be more certain that the true effect of an intervention is actually, the effect you get is the true effect. And so this is just an example of each of these dots being people in the population. If you sample more people, more blue dots, then you're going to get a more precise answer. And so you take your bullseye from this to this. So now, how are we going to improve the accuracy? So accuracy is really all about systematic error or bias. And so what that means is, let's say you've got all these dots are people in the population. The blue dots here show that you only sampled a certain subsection of the population, and your results are really only accurate and relevant to a certain subsection because of some bias that you had in your study. So this is an example here of a study where you've now sampled from a better view of the population. There was less bias, and you could be more confident that your sample and your study is accurate. And there's a little diagram here of taking a skewed study that had some bias in, getting rid of that bias, and then making the answer more accurate for what you were trying to answer. So just going to revise also some different kinds of studies. So if you hear about these terms, retrospective or prospective, retro just means past and pro means future. And so when you're looking at observational studies, you can look at a cross-sectional study, which is really just looking at a point in time, seeing what a cross-section of the population looked like, and then making some inferences from that. A prospective study starts in the present and follows people for the future. And a retrospective study starts in the present and looks backwards to see how patients behaved or what risk factors they had. So again, this is an example of a cross-sectional study where you have this, you've got a population of interest, and you're simply looking at them to see who's got a certain disease. So, for instance, that might be who's got lung cancer and who currently smokes, who doesn't have lung cancer and does smoke, who doesn't smoke and doesn't have lung cancer. And so that might be, and then again, indeed, what's that way found is that people that were smoking had more lung cancer. So that's an example of a cross-sectional study. And the key to that is that it estimates prevalence and not incidence. And the prevalence is just in the current population, how many people have a certain disease. It doesn't tell you how common it is in terms of it doesn't tell you that's incidence, which is how often new cases appear. So a case control study, this is, a retrospective study. And so this starts at a time point here in the present, and it looks backwards. So it says, so again, for instance, people with lung cancer, were they exposed to asbestos or not? And indeed, that's how they found it again, is that they saw people with lung cancer, they had some asbestos exposure. And the good thing about that is that it's often, if there's a long time between an exposure and an emergence of a disease, these are good studies for looking at that, because they're usually cheaper. And you wouldn't want to do a study where you were exposing people to asbestos and then seeing if they got cancer. But so this is really the only way of sort of finding that, and that's how that was done in the past. So that's a retrospective study. And then a prospective study is where you have a population of interest, you either give them an exposure or you see if they're exposed to something, and then you follow them up, and then you see who gets the condition. And I'm going to give you an example of that in a minute, and how that might be relevant to orthopedics. Again, that's just a reminder of retrospective and prospective studies. And so this was an example we had presented at BOTA a few years ago. So patients with 2B, 3B open tibia fractures, i.e. nasty open tibia fractures, what people did is they the author presented the study where they basically looked at all the patients that had fractures and had treatment. So the time the study was here, and they looked back. So this is a retrospective study. They looked back and they said, right, these patients with fractures, a certain number of them got this new fancy bone graft type treatment, and the others didn't get the fancy bone graft type treatment. And what they found is that, wow, patients that got this fancy bone graft, they've only got 2% infection rate, whereas the ones that didn't, they had a 10% infection rate. And so you might just say, well, that's great, then that's we should give everyone that this fancy new bone graft. But what we'll try and do now is to try and show that that is probably not the case, or we can't make that assumption, and that's really about looking at sources of bias. So bias here means that if we look through all the different stages here, in a retrospective cohort design, what we might have recall bias. So it might be that we don't actually find everyone. When we were starting here, maybe we don't find everyone that had this fracture and that had treatment, because they were done by a different surgeon or they were lost in some way. So you might not find everyone. So that's recall bias. The next is selection bias. So it might be that of these people that got this fancy bone graft, it was only the super fit people that got that treatment. It may have been that all the patients that were diabetic and had vascular disease, they didn't get the fancy treatment, and that was the reason they got their deep infection, not because that nothing to do with the fancy bone graft they got. Non-participation bias, again, that's for patients that may not have been may not wanted their data collected and didn't consent to have their data followed up. Performance bias, so this might be the case that, again, this team that were doing this fancy bone graft, they loved this surgery, they've got great enthusiasm for it, and the surgeons that did this, they were super meticulous, were giving lots of antibiotics, and therefore there were many other factors, not really to do with the bone graft, that caused this great infection rate, better than the other. And it was the surgeon that was, for other reasons, that was doing this and causing this effect. And then you've got attrition bias. So we'll talk about that in a bit, but it's more the case that not every patient is getting followed up and is submitting their data. So when you look, so on the face of that, you might say, oh, well, look, these have got two different treatments. One is clearly better. But when you start to look at these different types of bias, you realize that's not quite the story. So the first little half of the talk is there to talk about accuracy and precision, talked about different observational study designs and about some of the sources of bias to think about. And now when we're designing a clinical trial, we'll go forward and think about, why do we bother doing these big randomized clinical trials? And so we talked a bit about internal validity, and we'll also talk about external validity, which is really asking, are the results of the patients I treat, are they applicable? So was that study suitably designed so that it is relevant to the patients I study and that I treat? And why bother doing trials? They're expensive, they take a long time, they can be difficult to recruit for, but the whole point is that they improve the accuracy and the precision of your results, which I'll show you in a sec. So the question is, why do they need to be prospective, randomized, blinded trials? And the answer is that every word there really is designed just to eliminate a different source of bias. So when you're thinking about why are those words used, it's because of this reason. So the reason that you have a prospective trial, among other things, is that it eliminates that recall bias of people not being included because you didn't realize they were in the study in the first place. Why are they randomized? That's to decrease selection bias and confounding. So randomization means that you've got a subset of patients and you are randomly allocating them to have one treatment or the other. So there's none of this, oh, this patient has got vascular disease and is diabetic. Oh, I'm not going to give them the treatment. I'm going to give them the old treatment. None of that selection bias or confounding is relevant, because you're using randomization to avoid that. And then why blind? So that's so that the people that are doing the observations, that are measuring the outcome, are not unduly influencing the results. I'll talk a bit more about that in a sec. But there are ongoing problems with attrition. So if you don't follow patients up and you don't know what's happening to every patient, it might be that although the 80% follow-up you've got, things look good, you don't know what's happened to those other 20%. And even if they've got similar rates of dropout in both arms of the trial, you don't know why those patients dropped out. It might be that in 1 hour in the trial, those 20% of patients were so happy, they just disengaged with the study and off they went. Or it might be that they died. And obviously those are two hugely different reasons. And we just don't know what happens to those patients. And that's why it's really important to try and minimize attrition and get as much follow-up as you can. This is sort of an old study, but some old examples. I won't go through these, but it's just to say when you're designing a study, you want to be thinking about this word PICO, which stands for population, intervention, comparator, and outcome. So the population is simply you defining who your population is. It might be elderly people with fractures, it might be children, it might be people having a certain procedure, but you've just got to know who it is and you report that, so then people that are looking at the study can know who it's applicable to. And then the intervention, it might be a new treatment, and then the comparator, it might either be just standard care. You might just say, right, we're going to randomize people either just to have the new treatment, and anyone that doesn't have the new treatment is just going to have whatever else it is, which could be several things. So it might not be a direct comparison of one type of surgery from another. And then the outcome, there's all different outcomes you can use. Usually we like to use a patient-reported outcome because that makes the statistics a bit easier and it's easier to collect and it's a bit more objective than some other measures. Mortality, again, that's pretty objective, but most trials aren't really, mortality perhaps isn't the best reason, particularly if we're doing, for instance, like elective orthopedics. So when you're making a trial protocol, there's a few things you want to do. So you want to look at the background to a disease. So what is the burden of that disease? What's the current evidence around it? So you want to look at do a literature review to try and see, again, what the incidence or prevalence might be, so you know how many patients you can expect to get. And then the design, you can really, ask a statistician about whether it should be a superiority or non-inferiority or an equivalence trial. We won't cover that today. And then recruitment, you've got to ask, is there clinical equipoise? Do individual surgeons, will they randomize to this, or are they so ingrained in their own treatment that they won't sway from that? And so it's worth doing a survey or even a little audit to see if there is truly clinical equipoise. And then again, we talked about some of the inclusion criteria. You've just got to make sure that you're sampling the right patients. Again, if you're doing a hip fracture trial, it's probably not worth just excluding patients over 60, unless, however, you're doing a trial for patients with hip fractures that are young. And so you just got to be clear about what population you're trying to answer the question for. And then randomization. Unfortunately, randomization, again, just saying the word randomization doesn't cure the problem. So if you think about the Wolf trial, so that was a trial where they compared putting on, for patients with open fractures where they couldn't close the wound on the first surgery, they either randomized patients to having a vac dressing or another kind of dressing. So if you simply if the patient came in the door with a fracture and then you randomize them at that point, you would still expose yourself to various other sorts of bias. So if they were randomized before they had the surgery, the surgeon that might, for instance, prefer the vac dressings might be, again, extra meticulous if they knew they were randomized to that. They might wash out more, they might give antibiotics. Conversely, the patient that, if they were in the other group without the vac dressing, the surgeon might work really hard to sort of close the wound edges and make sure that there wasn't a big gap. So that would be, if you randomize at that point, that would still allow a lot of bias, particularly performance bias. So in this case, what they did is once they debrided the wound and they were ready to put a dressing on, that is what in theatre, that's when they randomized patients, all just to decrease this performance bias. So these are things you have to think about when you're designing a study. about when to randomize. And then blinding as well. You might hear about, you know, it was a single blind trial or a double blind trial. Really, when you're reporting a trial, you want to say who was blinded. So you might want to say this was a surgeon, patient, and outcome assessor blinded trial, because all of those different things will have different influences and different bias. So again, the surgeon might have some performance bias if you don't blind them. For the patient, there might be some placebo effect. For the outcome assessor, they can always, you know, often these things might be a bit fudged. So if for instance, the outcome was infection, and the outcome assessor had a bit of a bias, they might score patients differently. And yeah, it does happen. It does happen even if people think they're sort of pure and they don't have bias. You know, I've seen it where they just think, you know, I think that was related, so we'll call that a complication when perhaps it shouldn't have been. So that's blinding. You've got to think about, is it going to be explanatory or pragmatic? So explanatory means you're just doing a very tight experiment. So it might be that, for instance, with that wolf trial, you tell them that they're going to have a vac dressing on, they're going to have this exact dose of antibiotics, they're going to have exactly this kind of weight bearing, this kind of follow-up. Whereas in practice, in the big trials that we do in the NHS, that's often very hard, often because people have got lots of different views about that. But more it's because we like to do pragmatic trials where, because then we can increase generalizability, increase participation, and know what the effect of an intervention is, you know, in the NHS for the average patient. And yeah, so almost sort of finishing with that. So probably don't need to talk about baseline measures, but yeah, you've got to think about your follow-up. You might just want to answer a simple question, and you might think that that is a question you can answer and get a good idea of within a year, but you also might need to think again, for instance, you know, a patient doing a study on ankle fractures, you might then want to look a few years down the line to see if they're getting arthritis in the future, because it's no good if they get an early better function, but then they get worse arthritis in the future. So that's just a little think about follow-up. And then your sample size, there are these things to think about, which we won't cover today, about the standard deviation of the outcome measure you're using and the minimally clinically important difference. I'm not sure, you may have covered the fact that a study can be statistically significant, but that little difference might not actually be relevant to the patient. So there's this concept of minimally clinically important difference, where you know, to be truly effective, it needs to be not just statistically significant, but also clinically significant. So that difference needs to be measurable and meaningful to a patient. So I think we'll leave it there. And so all to say is that we've talked about clinical trial design. We talked about internal validity, which is really about accuracy and precision. And then we talked about external validity, which is about trying to make your trial as generalizable as possible, so that when other doctors look at it in the future, they can answer the question, is this study relevant to the population I treat? So hopefully we can discuss a few more of those concepts in the questions a bit later, if anyone has them. So I'll leave it there.
Thanks, Chris, for the lecture. If we could now move on to Emma's lecture, could you please share your screen?
Hi, can you see that okay?
We can.
Brilliant. Let me just put this onto slideshow mode. Hold on 1 second. Right, I hope this is going to work okay, because
we can't see you, Emma.
Yeah, I know my why is my, let me just put my, hold on. You could see me previously, so I don't know quite why. Let me just, my Mac is unfortunately misbehaving. Let's try this, hold on. No, it says the video started. Let me try one last time. There I am, excellent. So sorry about that, everybody. Well, thank you very much for inviting me to talk today. Can everybody hear me okay?
We can.
Great, fantastic. So I'm a consultant hand and wrist surgeon up in Middlesbrough in the northeast of England, and I am also the surgical specialty lead for hand surgery across the UK, which is a part of the initiative that the Royal College of Surgeons introduced to improve surgical trials across the entirety of surgery, essentially. So my remit as part of that position is to promote research in hands, particularly clinical trials, and really just to get people more interested in research and just to promote research, really. So I have been asked to present around systematic reviews and meta-analyses. So that's the next and the slightly different part of the research portfolio, I suppose. So I'm just going to go through a little bit about these. They're quite good. They can be complicated and sometimes a little bit confusing. So hopefully I'll be able to explain it to everybody. Now let me just do my next slide. So first of all, I'm going to go through what systematic reviews are, what meta-analyses are, why we need them, how you go about performing one if you wanted to get into that, and just some useful resources for people as well. So what is a systematic review? It's essentially defined by the Cochrane Handbook as an attempt to collate all empirical evidence that fits a pre-specified eligibility criteria in order to answer a specific research question. So it's a way of trying to essentially see the wood for the trees. It's a way of looking at a lot of information about a subject, collating it together and coming out with an answer, which I'll hopefully explain in a little bit more detail later. Meta-analyses, on the other hand, are a subset of a systematic review, and that actually uses statistical methodology to summarize the results of independent studies using the same statistics. So why do we need systematic reviews? Well, we can't always rely on the results even from well-designed single studies, such as the studies that Chris was describing earlier on. Single trials rarely answer all the clinical questions, and sometimes the incorrect results may be presented. And despite all of the mechanisms that Chris presented about reducing trial bias, there still may be some bias involved. The other good thing about a systematic review is because it assimilates a lot of information, a lot of different studies, it can help identify an area of uncertainty within that information and the current literature to guide further design of randomized controlled trials, for example. Synthesizing the evidence can actually help save lives, and I'll show you an example of that later. It helps guide funding for new trials. So the NIHR, the National Institute for Health Research, will use the results from systematic reviews to help guide where it's going to put its funding, essentially. And it also informs national practice guidelines. So the NICE guidelines, for example, will take evidence from systematic reviews and put those into practice. So just a little bit about levels of evidence. We've talked about randomized controlled trials. And then above that are the systematic reviews and the meta-analyses. So it is the most rigorous form of evidence that we have in the medical literature. So I said I would give an example of how a systematic review can quite literally save lives. So in the case of infant death from essentially cot death or SIDS, a systematic review looked at observational studies between 1940 and 2002 and concluded through their research that advising parents to place their babies on their backs to sleep could have saved over 10,000 cot deaths over that period of time. So and they came to this conclusion by assimilating a huge amount of data and comparing that data and comparing the results of all of the data. So these systematic reviews can be very powerful. So why not just do a literature review? Well, the difference between a systematic review and a literature review is essentially the quality and the rigor. So the evidence is high quality because it's filtered and screened, which I'll go through. There is a very specific method to it, so it's systematic. You have a detailed protocol. The systematic reviews tend to be less biased because it takes bias into account when it's looking at all of the different studies that are entered into a systematic review. It's reproducible and it has quite a narrow scope. So you have to design a question and try and answer that question with your systematic review. So for example, when we look at corticosteroids and head injury, a systematic review revealed uncertainty about whether or not steroids did more good than harm. This then led to a randomized controlled trial being designed to answer that exact question. And it was found that corticosteroids in head injury were actually found, if I just show you what was done next. Corticosteroids and head injury were actually found to be detrimental. So the randomized control trial that came off the back of this systematic review proved, in fact, in the Lancet, that corticosteroids were detrimental in head injury. So then how do we design a systematic review? We've already talked about the PICO criteria, and that can be used across all sorts of different studies. And essentially, we need to decide how we're going to design the question and who and which studies we're going to include in the systematic review. So what population do we want to look at? What intervention are we looking at? What's our comparator? What outcome measures? And which study designs are we going to look at? So there are different types of systematic review. There is an intervention review, a systematic review of observational studies, and also a review of diagnostics. And you decide which kind of systematic review you're going to undertake based on your research question. So how do you actually physically go about doing one of these systematic reviews? It's a lot of work, and people who've done them say it's very rewarding, but it is a huge amount of work. But it starts, as with everything, with phrasing your research question. What do you want to find? What answer do you want to come up with? Then you design a way of searching for all of your evidence. You filter and select your relevant studies, and then you extract the characteristics that you're looking for from the relevant studies. You assess the study quality, and then you analyze that data. And within that data, you can then perform a meta-analysis, which I'll go into later, and then present the findings. It's very important for a systematic review that we have a protocol, and this goes back to the rigor with which systematic reviews are undertaken. A protocol provides a framework for the review. It also aids planning. As I said, it's a lot of work, and it's very rare to be undertaken just by one person. So it aids at planning. It reduces bias. It also gives some access to peer review because you publish your protocol and then people can comment on that protocol. And it avoids duplication of effort to make sure nobody's done something similar. Now, there is the PRISMA checklist, and which helps to go through the process by which you would filter the systematic reviews. And you also would register your protocol on Prospero, again, to ensure that you're not duplicating the effort and somebody's doing the same thing as you. So as I mentioned before, you then design your research question and your strategy by looking at who you want to be in the study, what interventions you look at, what comparisons you're going to make, and what outcomes you come. Now, we mentioned PICO a lot in research, but it's a really fantastic way of designing an evidence-based question. So then we go on to define the eligibility criteria of the papers that we want to systematically review, and define keywords. So which keywords do we want to look for? Because we're going to have to search the literature. We're going to have to search, and we want to do a rigorous search using the same keywords for each paper. And by identifying the keywords, we can then formulate a search strategy. Now, the literature search itself is quite a complex undertaking. There are lots of different places that the data can be found: medical electronic databases, conference proceedings, relevant books and reviews. And what you want to make sure is that you actually are systematic, so you don't miss a body of literature that could affect your results, essentially. So the data sources, they can be either electronic or other, essentially. So the electronic sources, the Cochrane Central Register of Controlled Trials, other electronic databases, which you'll all have heard of, such as Medline, Embase, and then other sources. So you've got the grey literature, hand searching data, reference lists and trial registers, looking at ongoing studies and what their results are showing. So this is just an example of the areas in which there are lots of different places you can look for information. One of them is the World Health Organization, and another one, which actually isn't showing up here for some reason, it's showing up on my screen, is the US Center for Central Database for Trials. So there's lots of different areas that you can search to look for the trials that you want to compare. And then you want to screen. I said earlier that once you've identified your question and you've identified this vast array of papers that potentially could give you information about your question, you need to screen them. You need to assess them for quality so that you are comparing the best papers, essentially. So first of all, you want to screen titles, and then screen abstracts, and then screen the full text articles. And this is the bit that takes a long time. There have been a lot of electronic advancements in the last few years to make things easier. There is now EndNote software which can facilitate this, and there are some semi-automated systematic review tools that can be used to try and improve the or reduce the work, essentially, and improve the efficiency of your searches and your screening. So I was talking about the Prisma flowchart previously. So this is essentially what a systematic review will need to go through. So it's an identification process, a screening process, which I've mentioned, working out which papers are eligible and which ones you want to include. And bit by bit, the studies will be whittled down to the final set of studies that you will be able to directly assimilate into your systematic review after screening out a number of other studies. Now, there is also a risk of bias assessment that the Cochrane collaboration recommends, so that every single paper that you choose to put into your systematic review has to be scored from the point of view of being biased. And there is actually software that can help you with this as well, as evidenced on the right there. That's a program that will help determine the bias within a particular paper, for example. So you're looking specifically to try and reduce the bias from sequence generation. So in other words, are they randomized? Allocation concealment, if the patients or the participants are blinded, as Chris mentioned previously, whether or not the papers have an incomplete data set, and whether or not the papers are selectively reporting their outcomes, and other topic-specific design biases. And then each paper is ranked based on its bias as well. So essentially, the overview of systematic review, it's quite a complicated process, but essentially, you're identifying your question, you're writing a plan or a protocol, and then you search for your studies, essentially using the tools that I've mentioned. There's then a sifting process to sift out the studies that are going to answer the question and be relevant to the question that you're asking. You take the data from those studies and then assess the quality of that data from within the studies, making sure that you've done a bias analysis. Combine the data together and then discuss and conclude the overall findings. And this creates a systematic review based on all of the information that is available in the current literature on that specific question. It's then disseminated. And as I mentioned before with the steroids example, or with the SIDS example, this has real world implications for changing practice. And essentially, as I started, it allows you to see the wood for the trees. So then when we're talking about meta-analysis, this is slightly more complicated. It's essentially a statistical technique where you try and use statistics to pull data from more than 2 different studies. I'm not going to go into a huge detail about how you do this, but essentially, why would we do a meta-analysis? Why would we undertake it? Essentially, if there are conflicting studies, or you want to have to produce a precise effect estimate, then a meta-analysis may be useful. You need more than one study within a meta-analysis to estimate a treatment effect. And if you have you need to have similar outcome measures. You need to be able to assess what study data each study has and how the studies have undertaken their data analysis, and also know whether or not there are minimal differences in study characteristics to be able to actually undertake a meta-analysis. So there are a number of different stages. The first one is you summarize the statistic for each study. Then you pool the summary of the statistics, display the results graphically, which I'll show you a little bit about. That's called, usually used, a forest plot. And then you interpret the results. And usually this is a slightly smaller study that can encompass some of the data from a systematic review. So one aspect of the systematic review can then be delved more deeply into using a meta-analysis, or a meta-analysis can be a standalone undertaking. As with everything, it's always good to have a plan. The data analysis plan will include which comparisons are we going to make, what statistical methods are we going to use, are we going to try and do a subgroup analysis, so look for different bits within that data, and are we going to assess the sensitivity as well. So if we're talking about choosing a summary statistic for each study, it does depend what data that we're looking at, and choosing a statistics is really important. And I'm not a statistician by any means, so I work quite closely when I'm designing a study with a statistician to ensure that I get the most accurate plan, essentially. But it's very important to make sure that you know exactly what kind of data you have. And then you pull whatever that data is, you pool the summary statistics together and average the effect over all of the studies. And this allows you to compare studies to try and answer a single question, essentially. Now, people will say, well, can you average trials? Can you just average the results? Well, unfortunately, you can't, because of the weighting problem. So a simple average gives each study equal weight, but not every study is weighted the same. So some studies are actually closer to the true effect than others. So some may say that trying to average trials is a bit like comparing apples and oranges. To do that comparison, we have to perform meta-analysis, statistical conversion, essentially, to ensure that we're then comparing oranges with oranges. So when we weight studies, we essentially need to make sure that we have a bit more information, and that extra information produces lower variance. It gives more robust statistical results, and more participants and events are combined. Now, the wider the confidence interval, the less the weight, essentially. So all of this has to be taken into account when you're trying to design your meta-analysis. And then displaying the results graphically. So now that you've designed your meta-analysis, you've done the statistical conversion, and then you're going to try and display that information. And the classic way of displaying this is on a forest plot, which I'll show you briefly what a forest plot is. So if we're looking at the therapy, say, for example, review of therapeutic hypothermia for head injury, comparison is immediate hypothermia versus normothermia, and outcome is death at final follow-up. This is the forest plot bit. So this bit on the right-hand side there that you can see. And this is a way of trying to demonstrate. So each one of these names on the left is one of the papers that have been chosen. And this is a way of trying to combine that data in a diagram and in a statistical way that allows you to easily compare the results of these different studies. So as I said, each study is represented by a line in the plot, as represented on the left, and then the event rates of each study are listed. Then you have the effect estimate and the weight of each study, and then you have the forest plot itself. there's a lot of information here. I don't think you need to know it in this much detail. But essentially, what we come up with is an odds ratio. And then let's demonstrate. I'll show you. It's easier to see on a plot, really, to be honest. And this is the line of no effect. So there is an effect, there isn't an effect. So this is the line of no effect. This is the line indicating combined results based on the meta-analysis. And the meta-analysis result with width of the diamond indicating the 95% confidence interval. So in other words, looking whether or not it favors control or favors intervention, it favors intervention. So in summary, a systematic review allows us to see the wood for the trees in published literature. It can identify research questions, and it requires a rigorous methodology. A meta-analysis can combine data from multiple studies on a particular topic, but it's quite a complicated statistical undertaking, but again, requires rigorous methodology and a research question that can be answered. So I think that's everything from me. Hopefully I didn't confuse you all too much. It's quite complicated. I've also got a slide here for additional resources, if any of you want to look at this in a little bit more detail.
Thanks, Emma. We'll move into the Q&A session.
Yeah, so I'm just having a look through the chat now. I know Chris has answered a few questions in the chat, but there's one from Metwali. Is the PICO principle applicable in all types of studies or only for randomized controlled trials? Chris, do you want to just elaborate on your response to that?
Yeah, so it's just think about observational studies. You're using PICO, which is population exposure, comparator and outcome, and then PICO, which is an interventional study. Interventional means you're actually doing something to a patient and changing their care pathway in some way, and that would be population, intervention, comparator, outcome. And as I say, it's a bit blurred when often you'll have a study and said, oh yeah, a retrospective study. We look back and we saw, half the patients had hip replacements through this approach, half of them had a hip replacement through that approach. So it's it's debatable. Is that an intervention or is that an exposure? I wouldn't get too bogged down in that, but I would, in your mind, I would probably, unless they've been randomized, I would probably just try and think them as exposures, because that'll just remind you that there is so much bias in a non-randomized study. So if I were you, unless it's randomized or a systematic review, I would think of it as a peak, as an exposure, just to remind yourself that there's so much bias that you need to look for. That's that one.
Perfect, thank you. Then there's I also asked, what does pragmatic mean? And I think there was a follow-up question about an example of a pragmatic trial. Chris,
well, not when you've just done, come up with some bizarre recipe. I'm hungry now, so I'll let you explain that then.
Yeah, essentially, a pragmatic trial is to reflect a real-world situation, as you can imagine. For a randomized controlled trial, if you think of it as an experiment, then you could control almost everything. But if you were to then translate that into clinical practice, it might not always be feasible. So pragmatic is essentially taking into account real-world scenarios, what surgeons do day in, day out, and applying that to the intervention that you're testing. And that analogy of a spaghetti sauce, you can read it in the chat if you want.
But it's also about making sure that you don't make the trial too difficult as well sometimes, because if you want to answer a very specific question, you are I know it sounds weird, but you're not really interested in the rest. You want to make sure the rest is just done as per usual. So for example, you were mentioning that I'm the co-CI for this FLAIR trial. So all we want to know in our FLAIR randomized control trial is, if you cut through both tendons in zone 2, there's a little bit of your finger, and is the outcome the same if you repair one tendon or both tendons? And there's a lot of other things that go on with, so afterwards, after you've repaired the tendon, you get a specific kind of physio and all that sort of thing. But we have allowed that the choice of the rehabilitation to be pragmatic, so that it means that the surgeon isn't going to be put off being in the trial because they can rehab the patient however they would normally rehab them. The only thing that we're looking at in that bit of the randomized control trial is the surgical intervention. The rest is pragmatic, is up to the surgeon, is up to the team. And I think it does make the delivery of the trials easier, because it means you then don't have to specify a specific rehab protocol and have all of the different parameters put down for the rehab protocol as well. So it sometimes just makes the delivery of the trial easier.
Okay, yeah, and I think there was one on the MCID there, which was a bit niche, and I've answered that, so hopefully that'll be, you'll be okay. Let me know if you get more questions about that. And then about, yeah, you asked about where to find this, the next big idea. So I had a slide on that already, so I'll get that up there. And then, yeah, so yeah, the reality is the way you're going to find the new big idea is that you're just going to see it in your clinical practice, and you're going to be like, oh gosh, you know, I wonder whether we should use this suture or that suture, whether we should use a drain or not. And then, yeah, that's often how they come about. You go and you look on the, you look for a systematic review, and you'll either say, oh yeah, that's been answered, great, or you'll say, oh, it hasn't been answered, and then that might be a good idea to do a study. And then, yeah, again, either you'll be lucky and there's already a systematic review done, and it says, you know, we don't know which is best, or you'll be unlucky and there won't be one, and you might have to do one first, look at all the studies, and then see if there's an answer or not. So that's what you do. Other ways, and I would definitely talk about so the James Lind Alliance, because yeah, the issue with research studies, you need to get them funded, and the sort of the NHR is the taxpayer's way really of funding big studies, and they look very favourably on these James Lind Alliance priority setting partnerships. I'm not sure there's a separate topic on that, but basically they have a website where they publish the top 10 questions in various avenues, so complex fractures, knee replacements, shoulder problems, and you can just go, and I would, if you're not sure where to start, I would go on that website, look down the list, and pick one of the top 10, because that means that it's been made in collaboration with patients and healthcare professionals, and it's more likely to get funded. So that would be, if I had to give you one bit of advice, I'd say go and look on the James Lind Alliance website. Otherwise, you can ask patients what they want to do, and again, that's great. NICE also has recommendations for research in on their various guidance, so that's where a few of our studies have come from. So that's another place to look. Yeah, or you can you can just steal someone else's idea, and the reality is it's quite a lot of work to do a research study, and people often don't want to do a study, because so if you've got the time and the 10 years to sort of make it happen, then yeah, go ahead. All right, yeah, let me know if you've got any questions about that. But yeah, JLA, top tip.
You can also put in your own PICOs, and the NIHR often have a call for PICOs, and where essentially they want research questions outlined in that PICO format that we mentioned for clinical trials, and they assimilate a lot of information from different sources, so from patients, from clinicians, from researchers, etc., and then they will bring that all together and decide if they're going to put what's called a commission call out, which is where they have a question that they want to answer based on all the PICOs that have been submitted, and they ask for research teams to bid for that money. There's also a researcher-led bid where people can put in a bid for essentially their own research question to the NIHR to be funded. So there are lots and lots of different avenues to get involved. But if you don't want to be doing this, as Chris says, the 10 years worth of really hard work, there are loads of avenues that you can go down to be involved in research that don't involve, doing all of this work. You can join a research study, you can join the associate PI scheme. There's lots of different ways to get involved in research without necessarily having to do all of this hard graft.
Thank you, Chris and Emma. Is there a protocol for selecting your keywords in a systematic review? That's probably relating to your talk, Emma.
No, not really. I think it's all fairly protocol driven, but I think there isn't a specific framework or anything for collecting your data for your keywords, unfortunately. Oh, do you need my last slide again? I can see something on the chat there. Do you want me to just put that up?
Yeah, you can. Yeah. Feel free.
Oh yeah, just why if you are doing systematic review and you're looking for keywords, do speak to, if you can, someone that's done it before or an information specialist, because there are certain words that if you look on the various databases that sort of explode and give you better answers. So all to say is that, yeah, talk to someone that's done it before, because there is this like magic little thing that you can find that it's hard to find if you haven't done it yourself.
Perfect, thank you. Great. So Emma's shared the last screen if anyone wanted to have a look at that and the links. So we've got another question from Ramesh. In systematic reviews, we gather information from all different previous studies. So how is this effective study method? How is this an effective study method if all the information presented, sorry. Oh. Okay, I think he's trying to say that how is a systematic review novel since the information is already out there. I think that's what the question is trying to get at.
Yeah, I mean, it's a way of using the data that's already out there to answer a slightly different question, if you see what I mean. So it's a way of bringing the data together and choosing the best data on that subject to either identify that there is another question that hasn't been answered yet. So for example, in the head injury example, the meta or the systematic review that was undertaken looking at whether or not corticosteroids were beneficial or not in head injury identified that actually they hadn't asked that question yet. So that led to the design of a randomized controlled trial looking specifically at whether or not steroids were beneficial or not to that particular population. So it's a way of identifying, using all of the data to see whether or not the question that you're wanting to have answered is answerable with the data that you've got. And when it came to the example of the SIDS, then the actual answer to that question was within all that literature, but it couldn't be seen from all the individual studies that were out there. It was only by putting everything together and asking the question, you know, is the mortality affected by the position of the baby in the cot, that question was answered by using all of the data in the world literature over that 60-year period. So I think, yes, there are lots of different ways. So yes, it sounds like it's not novel, but it can identify areas that haven't been answered correctly within the data that's out there already.
Perfect. Thank you, Emma. I hope that answered your question, Ramesh. And closely related to systematic reviews, is there any specific databases to use in systematic reviews, and how do you ensure that all relevant studies are reviewed and captured?
Yeah, there are definitely data. So if I go back through, there's the Cochrane database, which I think I mentioned. Hold on, let's just see. There are a number of databases. So you've got your electronic and then your other sources. So it is very important that you make sure within your protocol that you've designed a way of not missing any studies, essentially. So you've got the Cochrane Central Register of Controlled Trials, and you've got your other standard sort of electronic databases, like I said, that you'll have heard of, Medline, Embase, that sort of thing. And there are also electronic methods of searching the data that help to sift through your search criteria, essentially, that have been developed in the last 10 to 15 years to help specifically with systematic reviews. Some are paid, something you have to pay for, and some are free. I've got examples of both, but I can add those to the, let me just see if I can get an example of those two up. Yeah.
Perfect, thank you. And the last question, I think, is how do you think AI can assist us with research?
Well, that
Chris,
sounds
do you
like a sort of pub question, which I don't think we can do. But yeah, no, I was trying to do this, trying to write a paper. Yeah, trying to write a paper last night, trying to use AI, and yeah, no, yeah, just obviously like nice little tasks, changing things from the present tense or the past tense to the future tense and back and forth. So yeah, writing. I'm sure it's going to make these systematic reviews much better. Yeah, so no, I think it's going to do pretty much everything other than no, I think it'll help recruit patients as well. It'll come up with nice ways of inviting them to studies. Maybe it'll look at previous studies they've been in, tone the sort of language. You might have individual patient consent forms that are sort of information sheets. Yeah, no, it's absolutely limitless. The only thing, what's it not going to do? It's not going to do, I know it's probably going to do the surgery as well. No, it's going to do everything. So, yeah, no, I think it's going to really going to take over. I look forward to it.
Yeah, all aspects. I think there's somebody asking a question about grey literature. That essentially just means the non-published information not published in commercial publications. And that's even more difficult to sift through.
Perfect. I think that was the last question. So if anyone has, we're just over 8. So if anybody has any questions, feel free to type them in the chat now or unmute yourself. Otherwise, thank you very much, Emma, and thank you, Chris, as well, for giving up both your evenings to deliver this talk. I hope everyone found it useful. I certainly did. And have a nice evening, everyone.